Here is a difficult case of ureteral access for ureteric stone impacted. How many URSL done? Sometimes impacted stone, you can see here in the mid-ureter, poses a lot of challenge. Here the first step we do is passing a guide wire. This is also example where C-arm has to be used. The surgeon who was doing had lot of air bubbles first. In URSL, please flush the ureteroscope and then go inside is the first suggestion. And the guide wire which fits curling, then immediately C-arm should be used. If possible, gentle dilute contrast also is better. The problem here is at 12 o'clock the stone will be impacted. You will be seeing only 6 o'clock. And second is lot of edema is there. He is trying to push at the 6 o'clock. So what happens? It sometimes perforates even if it is softened and goes up. See, it's going up. This is where the mistake one should not do. Guide wire going up freely doesn't mean that it is correct position. At this stage, C-arm might have been used because C-arm is a mandatory. Now the surgeon again going with a small ureteroscope and he again traces the guide wire. That is a temptation we will have. We think that guide wire is there, it is true guide, but it is a wrong guide here. See how it has gone here. It has gone below the mucosa and went up. If you go continuously, it will have shear effect on the mucosa and damages. Here what happened? A flower-like edematous mucosa is closing the stone and stone is not seen and it is not showing the lumen. That is the practical. This is very common. Sometimes you get away with experience, sometimes you don't get away. Here, the moment you see this guide wire which is going should be removed. Like this, it's removed. Now the senior has come into picture. He also uses a smaller ureteroscope. And what he does is, instead of passing guide wire, he will try to see the stone. See, now the stone is seen. And second important is, with every attempt, you take out the entire ureteroscope and keep coming again in. That is very important instead of constantly trying it. See, if the guide wire doesn't go, sometimes you see he has come back and again he is going, the rescue surgeon. It will be difficult for him also because certain amount of edema will be there at the site of the stone. Now he is manipulating the mucosa by seeing the stone, not passing the guide wire repeatedly. Guide wire passing repeatedly is not good. He is coming back and going and seeing all around the stone and then attempting the guide wire. Then under C-arm, this guide wire is seen. See, here the stone is there. He has seen the stone, he has seen the mucosa, then passed the guide wire. If the stone is seen and by the side if some space is created intelligently, then it gives space. If it is a small stone, like in this case, it given away the space and the surgeon has gone beyond this thing. And while coming back, pass the guide wire safely and see the mucosa, any damage has happened. Now the guide wire is seen safely in the PCS and not much attempt because edema will be there and you pass simply the stent and come out is better. Very few times primary handling can be advised, but here stenting done and came out. So passing the guide wire without C-arm is not correct. Passing the guide wire without seeing the stone is not correct. If the stone is seen with experience, try to see all around the stone and then pass the guide wire under the C-arm guidance. If possible, RGP is also not problem with dilute contrast. Ultimate aim is to pass through the normal passage without adding any extra insult to the ureter. Thank you.